This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with the Neurology Podcast and Thomas Jefferson University. Today I'm with Afsaneh Talai from UT Southwestern University in Texas and Dara Albert from Nationwide Children's Hospital in Ohio. Afsaneh and Dara are authors of a paper published in Neurology Education titled Educating Child Neurology Residents About Psychogenic Non-Epileptic Seizures. In this education research project, the authors sought to understand gaps in education on psychogenic non-epileptic seizures from both child neurology residents as well as child neurology residency program directors. Neurology Education is the latest spoke journal in the neurology family, and it can be found online at the Green Journal website and features articles across the realm of neurology education, including student education, resident and fellow education, or even topics in CME for practicing neurologists. And as more and more of us have all different types of learners rotating with us in our clinical spaces, the journal can really help you refine your teaching to both your peer providers in practice or those in training or even your patients. And so in featuring this article from Neurology Education, I wanted to talk with Dara and Afsaneh about both the current state of PNES education for residents in training, but also talk about some of the best practices that could be used, perhaps in educating both our trainees and our patients as we fill in these gaps. So Dara and Afsaneh, welcome to the podcast.
Thanks so much for having us.
Thank you for having us. Happy to be here.
So Afsaneh, I'm going to start with you, and I'm hoping you can give us a high-level overview of the study before we get into the details of what you did and what you discovered. How would you briefly summarize the findings of this paper?
Our group performed a needs assessment of current pediatric neurology resident trainees and the residency program directors. And we wanted to assess their perceived deficiencies in education on psychogenic non-epileptic seizures and understand what type of education is desired by these two groups so that hopefully in the future we can tailor a curriculum or a program for them so that we can improve education if we saw that that was needed. And so overall, our studies showed that while residents may report high levels of confidence in managing this condition, there's definitely a knowledge gap that they feel. And both residents and program directors want more standardized curriculum on this topic. Only about half the residents are even interested in caring for children with psychogenic non-epileptic seizures, which I think reflects, the uncertainty they feel around the diagnosis.
That contrast between confidence and knowledge and the fact that those two do not always correlate, I think is an important point to make, and hopefully we can dive into that a little bit more. And so turning to you, Dara, the project, as we just heard, sought to understand what are the education needs of child neurology residents when it comes to psychogenic non-epileptic seizures, or PNES. And in the introduction of the paper, you and the authors mentioned that there is some existing knowledge that distinguishing PNES from epileptic seizures is clinically challenging. Can you tell us, what did we already know about the state of clinical recognition and management for PNES, and how was this study going to sort of add to that knowledge or fill in some of those gaps or take it one step further?
We know that non-epileptic seizures certainly resemble epileptic seizures in a lot of ways. Somebody might have changes in their behavior, in their level of alertness, or shaking or jerking, movements that might resemble an epileptic seizure. And we know in clinical practice and also in the literature that these two entities can be confused. Sometimes people are recognizing these events, thinking that these events are epileptic seizures. And there is even data that suggests that patients are being treated as having epilepsy and given anti-seizure medication when indeed they don't have epilepsy, they have non-epileptic seizures. Now, a lot of that literature comes from adult data. We don't have a whole lot in the pediatric literature specifically, but given the similarities in terms of like clinical semiology for the events, I suspect that it's probably pretty similar in pediatrics. There was one really striking piece of data that I think illustrates this is in the ESET trials, the established status epilepticus treatment trial, where a group of researchers tried to see what is the best rescue medication to be given in the emergency room in patients in status epilepticus, I think upwards of 10 or maybe even 20 of the percent of the patients that they ended up treating for status epilepticus with medications turned out to have non-epileptic seizures. So that suggests that there's a lot of confusion out there in terms of how to recognize and differentiate these two entities clinically. And so we suspect that that would be true for trainees, especially who are still very junior in their clinical experience and knowledge, and child neurology residents still in training. We suspected that perhaps they would have some gaps in that knowledge or that ability to recognize or differentiate these types of events.
That's important. You make some very good points that, one, this is hard to do even in the context of, as you said, a trial targeting management of status epilepticus, presumably with inclusion criteria and experts sort of involved in that making this distinction is a challenge. And then building back again on what Afsaneh said, that while there may have been some lower levels of interest in treating this disorder, to treat epilepsy is to treat PNES, and the two are so hard to distinguish that can't have one without the other. So speaking of some of that confidence and some of that interest, Afsaneh, drilling down to some of the results, what did you all find with regards to the residents' current levels of confidence in their ability to recognize, to manage, to communicate to patients regarding PNES? And what are some of the needs for educators out there who may want to build a curriculum, or for societies in the field of epilepsy that want to build a curriculum? What are the educational needs that you identified in those realms that a curriculum might try to address?
We specifically asked about their confidence in communicating the diagnosis, since we know this is an area that previous studies have shown that neurologists struggle with, and even other healthcare professionals struggle with. 3/4 of our residents about reported confidence in their ability to communicate the diagnosis, which I realize may seem high, but we know that this is such a common condition and we want it to be much higher. It really should be a bread and butter diagnosis, just like you said, to have epilepsy is to have non-epileptic seizures in your differential. And then further, we know that the knowledge base is lacking because the residents, about 2/3, less than that, reported feeling knowledgeable in this condition, and only half felt their current education was sufficient on this topic. And so that really shows that there is a gap there that someone needs to fill with more education. Add to that all of our program directors reported a desire for a standardized curriculum on this topic. And based on the responses we received from both residents and program directors, what we really heard was that they really wanted a simulation-based education curriculum. And that makes sense because a lot of the diagnosis is communicating the diagnosis to the patients and families, and that's something that really needs to be practiced and observed for you to really learn it. And actually, Dara's group has even reported on their curriculum, and they've had really great success with it at their institution.
The skills that we're trying to teach here of talking to patients, talking to families, communicating the diagnosis does require, as you said, reiteration and practice, and simulating that certainly sounds like an appropriate way to go about that. Dara, I want to think about our listeners who are primarily clinical neurologists and are seeing patients with PNES, perhaps both children and adults, or one versus the other. And you mentioned that a lot of our literature in this area does come from the adult side, and we might be making some extrapolations to the child neurology side. Do you think that the gaps identified in the child neurology trainees that Afsaneh just walked us through could be similar in practicing neurology clinicians out there?
I think potentially yes. And I have certainly experienced throughout my career and during my own training different approaches to making this diagnosis and communicating this diagnosis amongst my colleagues and professors, some of which perhaps were helpful and some of which were less helpful. I think it's really striking. One of the most striking findings from this study is that only, I think, 50% of our residents report actually wanting to care for these patients. I don't think this point can be underscored enough, that this is a very common presentation, and this should be bread and butter and just part of what neurologists see and do. And we need to have a level of comfort, but also compassion for these patients and recognition that this is a hard thing for people to experience that these events are scary. So we need to have that empathy and compassion for these patients and how we approach them and how we communicate with them on a similar level as we would any other neurological diagnosis. And there's still some gaps there, probably in practice. There is some really good literature out there on differences in semiology between epileptic seizures and non-epileptic seizures. There's been a few really good papers that have looked at clinical distinction. And when you drill down on the semiology, which is what neurologists are really good at, right, is taking very detailed history and thinking very granularly about what's going on with the patient, there are lots of ways that we can pretty easily differentiate epileptic seizures from non-epileptic seizures. And then the second really important piece is communicating the diagnosis to patients and their families in the case of pediatrics in a way that facilitates understanding, and the patient and their family or caregivers are able to agree with and understand what's going on with them and to be able to accept and agree that that's the right diagnosis and move forward with treatment. So I think that's another potential gap that we are seeing in these data, but potentially may also exist out in the real world.
As we've been saying, this is something that should be bread and butter for practicing neurologists, child and adult neurologists alike. It's so common and it can be challenging, but there are some good resources out there, like you said, in the literature that could help us improve based on a semiological approach to making this distinction between epileptic seizures and non-epileptic seizures. Afsaneh, we've talked about these educational gaps. And so transitioning a little bit more to thinking about ways to fill those gaps and to teach these skills that we've been talking about. And you mentioned simulation as one example that the learners you surveyed identified as a way they would prefer to learn it. So what can this study tell us about possible strategies that we can employ to improve the educational methods, the way that we're teaching the clinical approach to psychogenic non-epileptic seizures?
The residents reported not only the desire to learn more about how to communicate the diagnosis, which, we've come to understand during this talk, that is one of the key components to getting the patients and families to accept the diagnosis and then go on to treatment. But the other area that the residents really reported wanting more education and direction on was how to direct their patient to the appropriate treatment. And we know for psychogenic non-epileptic seizures that psychotherapy and cognitive behavioral therapy are the ideal treatments, which is beyond the scope of our practice. But as neurologists, we can provide a lot of psychoeducation ourselves that can help bridge that gap from diagnosis to treatment by the psychologist. And so one area that also needs targeting is the psychoeducation piece of what things we as neurologists can communicate to patients and families in that initial diagnosis communication that we have with them. And so our residents and program directors both agreed. We gave them options of what types of education they want. And again, the simulation-based teaching was by far the most preferred method of learning. And so we need to be better about creating curriculum in that regard so that these residents can practice their communication, get out all the mistakes they make out in that practice so that when they're in front of the patient, they can feel confident in how they talk to their patients and families. Our other hope is that a lot of practicing neurologists who are out of training are also reporting difficulty with this diagnosis, with communicating it and talking about treatment. And so one of our goals is to also bring some of this education to some of our national conferences to further help our colleagues improve in their practice on this diagnosis, since we know it's not just trainees, but neurologists and epileptologists still could use some more education on this seemingly difficult, but really at the end of the day, straightforward diagnosis that just needs a little practice.
And thinking about the way we teach this is depend on the audience and the location that we're teaching it within a residency training program, perhaps developing, like you said, simulation curricula that can be applied to a group of residents, but that may not be as feasible in a CME national conference setting. What are some key clinical lessons that you think are really critical to include in future curricula that are going to help those recipients really better recognize and perhaps more importantly, manage the care of patients with PNES?
The first step is really making the correct diagnosis, recognizing the semiology features, reviewing videos. So curricula should include not only discussion of semiology, but ideally recorded events, reviewing videos of patients having events, and also hearing descriptions of events. What are the typical ways? I mean, there are a lot of common themes, at least in my clinic, that I hear from patients over and over and over again. One of the key questions that I have found to be so helpful in recognizing or differentiating these events from epileptic seizures is this very simple question of, do you have warning symptoms, first of all, which most patients do have warning symptoms before they go into their event. And then, have you ever been able to hold off or stop an event from coming or progressing once you felt your warning symptoms? And many times the patients say yes, and I can have very high confidence that that is a non-epileptic seizure, because you would not have any sort of voluntary control over an epileptic seizure, right? So it's these key history-taking questions that are very, very useful to clinicians to be able to recognize, to ask questions about the semiology and recognize distinctive features that suggest epileptic seizures or that suggest non-epileptic seizures. And also watching videos of semiology, again, to drive home that point of what do these events actually look like and what do they feel like? What are the subjective symptoms that people experience? And then once we have been able to accurately make a diagnosis, then the next really important step that is actually really the first step in treatment is that communication of the diagnosis and some psychoeducation, as Afsaneh was talking about. We don't need to be psychologists or psychiatrists. That's outside the scope of our practice, but we can have some sort of psychologically minded verbiage that we use to communicate with patients about what these events are, what are some of the precipitating and maintaining factors, predisposing factors to help them understand what's going on and get them ready for the next step, which would be cognitive behavior therapy with a psychologist, getting the patients and their families on board to move forward with treatment.
I really love that question you highlight about patients being able to abort or stop their event before it progresses. And I'm looking forward to the clinical paper you're going to publish on the sensitivity and specificity of that question so that we can feature it again on the podcast. I've been speaking with Afsaneh Talai from UT Southwestern in Texas and Dara Albert from Nationwide Children's Hospital in Ohio about their paper published in Neurology Education titled Educating Child Neurology Residents About Psychogenic Non-Epileptic Seizures on the Green Journal website, following the link to the journal Neurology Education. Dara and Afsaneh, thank you so much for joining us. This was fantastic.
Thank you so much for inviting us.
Thank you so much for having us.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.